All right, well, let's get started. My name is Fiorella Carwas. I'm the health educator for the Virginia Poison Center. I'm co-hosting with Jennifer Eskridge from the Oregon Poison Center. Special thanks to American Association of Poison Control Centers for their partnership on this project. We hope you find this webinar useful. We know the social and environmental conditions created by COVID-19 may be intensifying substance use conditions amongst members of our communities. A few housekeeping items. Please mute yourselves, and we will communicate through the chat box. Feel free to take a couple of seconds to locate where the chat box is. We will also have a good amount of time towards the end of the webinar for a Q&A. Well, let's start with me introducing the speaker, Dr. Gillian Beauchamp. Well, she is a member of the Medical Toxicology Fellowship and Emergency Medicine Residency faculty at Lehigh Valley Health Network. Her research, education, and administrative areas of focus are opioid stewardship and linkage to treatment for people with substance use conditions, stigma, and pharmacotherapy to support recovery. All right, well, let's give you the time to talk. Thank you, Gillian. Dr. Beauchamp.
Thank you so much. Thanks, Fiorella. All right, welcome everybody. Thank you so much for joining today. My interest today really is in sharing a few ideas with you and also hearing some of your ideas. And as Fiorella mentioned, we'll be using the chat box, and a few times throughout the talk, I'll be asking for some of your input. So I would love it if you'd be willing to do that. We're going to be talking about a pandemic, obviously referring to COVID-19, upon an epidemic. And that epidemic is really the epidemic of substance use conditions that our country continues to struggle with and has done so for many years. And my goal for today is that we're going to be talking about understanding substance use conditions. We'll talk about and define stigma and what we can all do after this webinar today to try to work together to reduce stigma. We'll talk about defining substance use disorder or substance use conditions so that we have a better understanding of how a person may develop a substance use disorder. And we'll talk about some of the approaches that can be taken in helping someone to enter recovery, in whatever recovery is defined for that individual. So let's go ahead and get started with a little bit of background. As I think we're all very well aware, our communities have been struggling, particularly during this period of a really unprecedented isolation in our communities. And while we're focusing on substance use disorder today, there are a number of conditions where isolation can be potentially deadly. And many people in the recovery community say that the opposite of recovery, the opposite of addiction is not abstinence or recovery necessarily, but it's connection and community. And what the data that I'm showing here is really just to remind us that during the pandemic, which has now been superimposed upon our ongoing epidemic or crisis of substance use conditions, that we have a number of individuals who are truly struggling from what we call diagnoses of despair. So the data that's up on the screen now comes from the Centers for Disease Control and just reminds us that when we take a snapshot, a survey of people, of adults during the COVID-19 pandemic, this is looking at June data, so pretty deep into the pandemic. We saw that 31%, so almost a third of adults, had some sort of symptoms of anxiety and depression. That almost a quarter of adults had some sort of trauma or stressor-related symptoms. That 13% of people, so 13 out of 100, had started new substance use or had increased existing substance use. And many times this has been a way for people to cope during the pandemic crisis. And very frighteningly, 11% of people, so 1 in about 10 people, have seriously considered suicide. So this has been an incredibly challenging time. And for diagnoses where connection really is part of the healing process, like many psychiatric issues, and especially with substance use conditions, the isolation really mandated by the situation during the pandemic has been particularly challenging for people. And I think in many ways has exacerbated some of the problems that people face. Now, you might think that sheltering in place, that being at home with loved ones, with family, may have improved some of these conditions. And in some cases, that really was the case. People had time with their families, with their loved ones, were away from some of the stressors, say, of school or work, and did very well. Others, however, particularly individuals who have triggers that are present in their homes, say people who potentially trigger that individual to use a substance in a harmful way, or maybe worsens some psychiatric issues. For people who struggle with their home environment, who perhaps live in a traumatic environment, maybe victims of interpersonal violence, of other trauma, of abuse, these individuals have been at particularly high risk. So really, when we look at this type of data, this is a reminder that behind closed doors, as many people have sheltered with their loved ones, with their families, this has also caused some issues for particularly vulnerable individuals in our communities. In particular, when we look at poison center data, and poison center data is so interesting because, as many of you know, poison centers are a resource that are available 24/7. And so people can call in to ask for advice, to report exposures, potential exposures, to ask questions about potential poisonings. And this could be products around the home, this could be over-the-counter products, these could be prescribed medications, these could be EMS, police, fire, or hospitals that are calling in for advice. What poison centers have noticed is that there have been increases in reports of self-harm attempts, of accidental exposures to household products. And we know when people shelter in place, that the products that are available around them, particularly to vulnerable individuals like children, can increase risk, particularly from accidental poisoning. That harmful substance use is on the rise, as we just saw with our CDC data, and that medication errors are on the rise. We have multiple people sheltering in place, multiple medications that are out and available. And what I think is most interesting about poison center data is that we find in many historical conditions that poison center data can be sort of like a canary in the coal mine, where we get an early warning about issues in our communities. We start to see spikes in phone calls, and those resources are accessed essentially live 24/7. And that data is tracked and processed, it's de-identified, right, and tracked. And what we're able to do then is look for patterns. And as an example, not only in the United States, but also in Europe, we are seeing increased accidental exposures among children, for example, to household products, as people are worried about the coronavirus and cleaning their homes, right, wanting to bleach surfaces or use other cleaning agents. So the poison centers, again, just provide that little glimpse into people's lives and their homes and their workplaces to see where poisonings might be happening. So as we look at this pandemic upon our existing epidemic of substance use disorders, how do we move forward? I think many of us in our communities have felt a lot of despair, a lot of helplessness. And what I'd like to outline here are just some thoughts on some things that we can do. And the images that I'm showing here, you'll see an individual there holding a bottle of alcohol. What we know, particularly during the early days of the pandemic, were that alcohol sales skyrocketed across the United States. There was a particularly large spike early in the pandemic, which we believe was due to people stockpiling alcohol. We know that people were worried about not having access to alcohol, both for recreational use, but also, say, for individuals who have become dependent on alcohol and who can actually develop a life-threatening withdrawal syndrome with cessation of alcohol use. And so, indeed, in some states, alcohol was made available to individuals with alcohol use disorder by special pickup or delivery to help prevent life-threatening withdrawal syndromes that would have otherwise landed people in the hospital or emergency setting where we know that exposures to the coronavirus were particularly risky. The other images show that we've been using technology, just like we're doing here as we gather via webinar, that we're using technology to try to increase access to care, whether it's through virtual visits, doing counseling, for example, for psychiatric issues or substance use conditions by phone or by an application on a smartphone or a computer, that we're really trying to move rapidly as we think outside the box and say, how do we bring care to the people in our communities? And really, poison centers have been doing this for many, many years, right? Always available, always there, resources really at the fingertips of our communities. And the other image is naloxone, which is the reversal agent or the antidote for an opioid overdose. And particularly concerning during the pandemic is that because the use of opioids in many ways, because of the way our federal laws are set up, need to be obtained through underground sources. So through dealers, for example. What we know during the pandemic is that because the illicit supply chains were very much altered by a lot of the issues, the logistics around the pandemic, we found people were exposed to a more potent, more dangerous supply of opioids, that access to opioids was very different than it was prior to the pandemic. And it became very much more important to get naloxone into the hands of anybody at risk of overdosing from an opioid or anyone who might be in the presence of somebody at risk for overdosing from an opioid. So, looking at those few examples, I want to summarize 4 ways that we can move forward as a community together. So the first is preventing new cases of substance use disorder. And one of the main ways that we're doing that in the medical field is to look at how we're prescribing medications, whether it's opioids, perhaps it's sedating medications like benzodiazepines, perhaps it's stimulants that are used for many medical conditions. That we need to be very, very careful at how we prescribe those medications. We know when we look over time, starting in the late 1990s, that one of the clear contributors to the development of the substance use crisis was indeed prescribing approaches. That we need to learn lessons from that, what we call the first wave of the opioid crisis, where people were overdosing. This is in the early 2000s on prescribed opioids. And opioids were prescribed in very, very high doses. And what we learned from that first wave of the opioid crisis is that we really need to be careful about how we prescribe opioids, screening patients for underlying risk factors, for the development of an opioid use disorder from prescribed opioids, making sure we're adequately managing pain, but doing so in the safest and most effective way, and that we're screening patients for adverse outcomes from prescription opioid use, developing dependence, tolerance, and further opioid use disorder, taking the medication harmfully, diverting or sharing the medication with others, and that if we monitor people who are prescribed opioids, when opioids become an important part of medical care, that we're doing so with the utmost respect and caution. The second step is reducing stigma, and we'll talk about this quite a bit today. that if people feel that they will be judged if they come to us for care, if they call a poison center, or if they call 911, or they come to a hospital, we know, and this is a big lesson learned from our HIV/AIDS crisis, that if people fear they will be judged, they will not access the care that they should and need to access. And so we, as providers of that care, as community members, as people who work in all types of areas across the community, need to reduce that stigma so that people know that they are supported, that they can reach out for support and help, whether it's to law enforcement, to EMS, to hospitals, to their religious institutions, their teachers, their librarians, whoever it may be. The next prong is really treating people who have already developed a substance use condition. And this is important because many, especially medical institutions, have said for a few decades now, we aren't specializing in substance use conditions. This isn't something that we do here. And that includes hospitals, emergency departments, offices and clinics. And so what we are asking our communities to do is to say, yes, we will provide resources and care for people who are experiencing substance use conditions, that people are welcome through our doors, into our emergency departments, our hospitals, our offices, our clinics, that if 911 is called, that our EMS providers are trained to better understand substance use conditions, so that again, people who have already developed a substance use issue can access the care that they need. And finally, harm reduction. Harm reduction has been a big part of a lesson learned from managing the COVID-19 pandemic. We know there's risk with being among people, with going to work, with providing essential services, but we mitigate or minimize that risk by keeping ourselves as safe as we can, by wearing masks, by wearing gloves, by washing our hands, right, by using sanitizer, by cleaning surfaces. Similarly, when we look at substance use conditions, we acknowledge that there are harms that are just simply part of our substance use crisis, that are part of using substances, and that we do our best to reduce those harms. And the way I like to think about this is that we do harm reduction every day. We wear a helmet when we ride a bicycle. We keep a fire extinguisher near the stove. We drive, even though we acknowledge driving can be quite dangerous, but we wear a seatbelt. When we think about harm reduction for substance use disorders, we think about things like naloxone. As a medical specialist, I don't see naloxone as enabling opioid use the way some people do. I don't see seatbelts as enabling dangerous driving or fire extinguishers as enabling dangerous cooking. I see that harm reduction is an approach that we can all take to reduce harm. We say this is an activity I'm going to engage in as a human. I'm going to get up today. I'm going to drive. I'm going to go to work where I could expose others or become exposed to a potentially deadly virus. I'm going to cook, but I'm going to reduce harm by wearing a seatbelt, wearing a mask, and keeping a fire extinguisher at the ready. And this is the way we view naloxone, as well as many other harm reduction approaches, such as safer injection practices and providing safer injection supplies and education, and access to safer consumption supplies. Let's talk about stigma. I want to define stigma for everybody. Again, this is a big lesson that we learned over the decades from multiple crises, including our HIV/AIDS crisis. Stigma is a mark of disgrace that's associated with a particular condition. And what that stigma does is it sets that person apart from others in the community. So when a person is labeled by, say, their condition or their illness or their situation, they're no longer seen as an individual, but they're seen as part of a stereotyped group. And negative attitudes and beliefs towards that group create prejudice, which leads to negative actions and discrimination against that individual. And we know that because stigma reduces the value of people in the eyes of the community and maybe even the government, maybe part of our medical system as well, that we know that stigmatization is one of the major obstacles to improving care for people with various stigmatized illnesses. And our awareness of that is growing. Stigma is such an important issue to address. What I'd love for you to do in the chat box is to think for just a moment about the types of conditions that are often stigmatized in our communities. So as you think about various disease processes or social situations that people might be involved in, or ways people look or appear, what types of conditions have you heard of that you feel are stigmatized? So again, the definition is that people are labeled by that condition, that people are judged by that condition, and potentially set apart from others and viewed as less valuable. So perhaps have a harder time accessing the care that they need or deserve. So if anyone has any ideas, please put them in the chat box, and I'll continue to keep an eye on those. So thoughts on conditions that may be stigmatized. So I'll move on and I'll come back to some of those conditions as people put those in the chat box. One of the key steps to reducing stigma is to seek first to understand, then to be understood. And where this is really important is around substance use conditions. So what I want to talk to us about today is developing a better understanding of substance use conditions, so that by seeking first to understand that person that's in front of us, whether it's a friend or a colleague or a loved one, that if we can seek first to understand, that we can chip away at that stigma that people experience. When we look at the brain, what I wanted to point out here is that deep in the brain, on this image here, it's in orange if you see colors with an arrow that says reward pointing to it, that all of the activities that we do as humans to stay alive, right, to keep ourselves well as a part of the community, eating, drinking, having sex, nurturing others and ourselves, all of those activities stimulate the circuitry in the brain's reward system, right there deep in the brain. And our brain neurotransmitters, like dopamine, which you may have heard of, basically those spike in terms of amounts that flood the brain and give us a pleasurable sensation if we do something that is helpful or protective towards us. Now, say we do something like we feed ourselves and our family, or we do really well at our job and we get a promotion, or our favorite sports team wins the game or the Super Bowl. We get that spike in that chemical and our brain says, you know what, that was a good thing to do. Why don't we do that again, right? And what that does is allows our very, very primitive, deep part of our brain to tell us, to remind us with positive reinforcement to continue to repeat activities that are pleasurable and rewarding. So this part of the brain developed very nicely as we learned how to survive as humans. So when we learn to feed ourselves, right? We get something to eat, we learn to hunt and gather, and we find that meal, and our reward center rewards us, and we say, good, I'm going to do that again. Now I'm going to have a better chance at survival. What happens with all of the substances that humans have ever become potentially addicted to is that those substances hijack the same part of the brain, the reward center of the brain. And so the reward center of the brain that helps us get through life, that helps us protect ourselves and our family and survive, gets hijacked. And when the brain gets hijacked, those substances, perhaps it's nicotine from cigarettes, or perhaps it's alcohol from beer, wine, liquor, perhaps it's a stimulant like methamphetamine or cocaine, or an opioid like a prescribed pill like oxycodone, or perhaps an illicit opioid like heroin or fentanyl. We get that spike in dopamine, and the brain gets hijacked and says, you know what? Let's do that again as soon as possible. And that compulsion to redose, to repeat that rewarding sensation, really hijacks the brain. And what happens over time is that those substances replace those other relationships that are typically rewarded, those relationships that help us live a full life. So relationships with food, with our family, with caring for ourselves and others, right? With our careers and our work. Those rewarding behaviors are replaced with attempts to redose that substance. And for many people with severe substance use disorder, most of any 24-hour period is spent actually in a state of needing to redose that substance, looking for that substance, planning to obtain that substance, looking for that brief rewarding system. And over time, what happens is that those chemical surges, those dopamine surges, become smaller and smaller and smaller. So to get that same effect, you need a higher and higher dose. So not only have you replaced other rewarding activities, you need to use a higher and higher dose of that substance, again, whether it's nicotine or a stimulant or an opioid. And over time, you are simply using that substance just to feel normal, to prevent a withdrawal or sickness from not using that substance. So a substance use disorder is defined as a stress-induced, genetically mediated, primary chronic disease of the brain's reward, motivation, memory, and related circuitry. And the stress-induced part gets at the fact that many people with substance use conditions have experienced an adverse life event or an adverse childhood event, what we call ACEs. Genetically mediated gets at the fact that about 50% of anybody's presentation for a substance use condition, or how they present to the community, is mediated by their genetics. What you can pass on through your blueprint, your DNA blueprint, is a tendency or predisposition to develop a substance use condition. Primary chronic disease of the brain's reward, motivation, memory, and related circuitry gets at all the pieces we just talked about, where rewarding behaviors that help us survive give us a rewarding signal in the brain, and that reward pathway gets hijacked by all of the substances to which humans have developed dependence, tolerance, harmful use, and potentially substance use disorder around. Substance use disorder is a complicated disease because the brain is the very organ in the body that we need to process this condition, to manage substance use conditions. Denial can be part of it. And if you've ever known someone with a severe substance use condition, accepting that diagnosis can be very challenging. Presentation and prognosis, so how people present as having a substance use condition, and prognosis, meaning how well they might be able to do, is very variable. When we think about all substances on a spectrum, we can think about people as having, say, a nicotine use disorder, who really spend a significant amount of time accessing that next cigarette. So if you've ever known someone who's run out of cigarettes in the middle of severe weather, and will actually go out in severe weather to obtain a new box of cigarettes, that's the reward center of the brain saying, you know what, I need to do whatever I need to do to get that next dose. That can vary tremendously from person to person, depending on some of those underlying risk factors, underlying trauma, what a patient's been through, what their genetics are like. Substance use conditions are culturally and politically complicated. These are conditions that challenge our societal values and norms. And sometimes people with a severe substance use condition can actually get in trouble, can develop criminal justice involvement. And sometimes that's because that reward center of the brain, that compulsion to redose, is so overwhelming that anti-reward part of the brain that says, I don't want to feel sick and in withdrawal. I need to redose just to feel normal. And that sometimes people go to extremes to obtain that next dose. And relationships fall apart. Jobs can fall apart, right? People can get themselves involved in trouble. And unfortunately, what's very complicated in our country is that there are a number of criminal justice ramifications around substance use conditions. We tend to take a moral failing view to incarcerate people for substance use conditions rather than addressing this as a medical condition. And while many of our criminal justice systems have begun to pivot and to try to provide substance use treatment as part of incarceration, we know that there are large numbers of community members who are incarcerated for complexities around their substance use conditions, and that this makes it very hard for people to access the care that they need. When we look at treatment, we know that the disease process is so complicated that the approach is going to have to be really complex, right? That the recovery journey needs to be individualized. Many times licensed, standardized drug and alcohol treatment can be quite rigid, and not everybody fits into those standardized approaches. Everybody's a little bit different if you think about all of the factors that are involved in developing a substance use condition. The journey is really individualized to the person. For one person, recovery might be continuing to use substances, but perhaps reducing harm, using safer equipment, beginning to cut down on the dose to prevent harm, using with Narcan available. For another person, it might be cutting back on the number of cigarettes or the number of drinks used in a sitting. For others, it might be complete abstinence, where someone says the only way I can get better is to completely stop my exposure to this substance. It's important to treat people's co-occurring medical and psychiatric disorders as well. If we're not treating someone's underlying bipolar disorder, depression, anxiety, post-traumatic stress disorder, managing someone's adverse childhood or life events that have predisposed the person to their substance use, then we're going to really struggle to help that person to meet their recovery goals. Management of triggers is important. We call this people, places, and things. So many times part of recovery is simply making some new decisions, some behavioral changes around those exposures, staying away from certain people who potentially trigger a person to use a substance, maybe driving home a different way to avoid that neighborhood bar or the place that you always buy cigarettes or the place where your old dealer can be found. Things that trigger substance use. And really what that is allowing the executive function, what we call the frontal and prefrontal parts of the brain, fold around that deep primitive reward pathway to say, let's use our executive function, our really good decision-making part of the brain, to say, as I let my reward center heal through whatever that recovery process looks like for me, cutting back, abstinence, whatever it might be, being on medication, I'm going to begin to retrain the brain to make those new decisions, to rebuild those relationships, to avoid those triggers, and to be really mindful about what some of those reasons are that somebody might use a substance. Medication to support recovery, sometimes called MAT, or medication for addiction treatment, sometimes called medication-assisted treatment. Medications like buprenorphine, naltrexone, which can be used to help heal that reward center of the brain, to prevent someone from withdrawing, from craving that next dose, to allow that brain to settle so the person can feel like themselves again and can approach their recovery journey in whatever way works for them. Spirituality is important for many people and an important part of the recovery journey. Sometimes this can be breathing exercises, mindfulness, doing yoga. For many people who are religious, re-engaging in their local religious institutions have a very important role to play. And then time. It takes time for the brain to heal, months to years, and recovery is a lifelong process. So what I'd like to do, and I'm seeing in the note notes on the side here that I think that looks like that maybe that the chat box is disabled, and that questions are going in the question box. So what I'd love to do, I know, so I probably missed any comments that were made. The prior question was about what are some of the conditions in our communities that are stigmatized? And the question I'd love to ask you now is, what types of labels have you heard used for people with substance use conditions? So perhaps what we could do, I'll see if I can open the question box here. And if not, let me see if I can, if not, I may have to ask from some help from our moderators here to...
Dr. Beauchamp, can you hear me?
Yes. Yes.
Great. Hi, everybody. I just want to make a quick announcement. It looks like the chat box is disabled, but folks are making comments in the question box. And you can view the question box by clicking on that gray header and click the undock or the pop out button to expand the view and see all of the questions coming in. We did get some responses for your first engagement question.
Oh, good. Yes. So I can scroll through those now. Wonderful. So I will highlight some of those here. So liver cirrhosis, excellent. Eating disorders, often stigmatized. Obesity, yeah, being overweight, excellent. Any physical or mental disability, great, often stigmatized. Dementia, great. Mental health, various disabilities. Homelessness, being schizophrenic, excellent. So many mental illnesses are stigmatized. Again, eating disorders, very good. HIV, excellent. These are really, really excellent. And now looking at some of the labels that you've heard for people with substance use conditions: druggie, addict, hopeless. These are excellent. Users, being low income. These are excellent, good. So these labels are types of labels that we would consider to be stigmatizing. And acknowledging, as I mentioned before, that stigma prevents people from accessing care. We have to acknowledge that if we don't address stigma, that we are stuck in an endless cycle of diagnoses of despair, and that it's going to be really important for us to move on. I see a couple more here: junkie and loser. These are excellent. Really great, everybody. Okay, so what I'm pulling up on the screen now is, I think, one of the most important take-home messages from today, that if we can use person-first language, we might be able to create a shift in our communities, and maybe even just for one individual who's struggling with a stigmatized condition. So people had great ideas in the question box there, that addict, alcoholic, junkie, right, abuser, that those are stigmatizing labels. What if instead we shift that language to say, all right, all I need to remember is to see the person in front of me as a person first. So a person with a substance use condition, a person who uses drugs, a person in recovery from a substance use disorder. Instead of a criminal, we'd say a person with justice involvement. Maybe instead of a schizophrenic, we'd say a person with schizophrenia, or a person with diabetes, right? A person experiencing homelessness. And one thing I will note is that in the recovery community, many people are actually taking back some of the stigmatizing terms like addict. And we would certainly, in the medical field and in the community, not ever intend to tell people how to describe themselves. But what I would suggest is that if I'm working with a patient with a substance use condition, and they say to me, hello, my name is Mary, I'm an addict, I would say, Mary, I'm so grateful that you shared that with me. And I am here to support you. As a person with a substance use condition, I'm here to meet you where you are and try to sort through how to best support you and your recovery process. So I'm reframing. Mary can say addict. I'm going to reframe with more positive language. And I would like to do that, whether it's to my loved ones, to my community members, my colleagues, or my patients, that I would say, I'm going to work to just pay attention to the words that I use and maybe reflect back a more positive term. And in doing so, perhaps that person in front of me feels more welcomed, that I'm there to support them, that they can come through our doors and see me in the emergency department or the hospital or the addiction clinic or whatever it might be, that we are there. And if we can do that at our schools and libraries and workplaces, at our medical settings, wherever this might be, that maybe we shift, right? Maybe we reduce that stigma. If you're having a conversation with somebody and you're having a hard time understanding why they're in the situation they're in, right? If you've had, say, a loved one struggling with a substance use condition, that what you're seeing on the screen now outlines what we call motivational interviewing. And the idea is that you are there to listen, to receive input from that person, and to reflect it back to them. You're not there to fix them. You're not there to be an expert. And the way this is done is that the ideas come from the person in front of you. You're evoking that person's ideas. That you are then avoiding being the expert in their lives and saying, I'm here to collaborate with you. You have autonomy. You have a right to make decisions to change or not change today. I'm going to meet you where you are. I'm going to be compassionate. And my goal is just to reflect back what your experience is. In the medical field, what we are working to do is to take this approach. Rather than say, as a physician, I sit with a patient who is struggling with a substance use condition, and I say to myself, what's wrong with you? What do we need to do to fix you, right? What I instead do is I take a moment, I seek first to understand, and I evoke the ideas from the patient. Instead of saying what's wrong with you, I say, what have you been through? Tell me what you've experienced. What have you been through that got you to the place you are today? Tell me about those experiences. And that gets at their family history, the adverse child and life issues that they've had, the trauma that they've experienced, right? What their substance use trajectory has looked like, what's important to them, and will therefore contribute to their recovery journey. Again, if you think of yourself as needing to fix someone, it's really, really difficult to sit with someone with a substance use condition. And in our communities, we make a habit of taking what I think is an unsuccessful approach. We look at a person and we label them and we say, you're an addict, you need help, you need to go to rehab, or you need to be incarcerated, right? We label, we judge, and we try to fix. We say, let's lock people up, right? Let's force people to do what we feel is the right thing. Instead, if we take a step back and say, let's figure out why people are experiencing what they're experiencing. What risk factors have they experienced? What has their life been like? What are their barriers to care? And by evoking that motivation, that history, that experience, we meet the person where they are and we figure out what might work for them. Rather than trying to fit people into standard approaches to care, we say, I'll be here to listen, to reflect, and I'm going to meet you where you are in your process. One huge message for today is that recovery is probable. I think those three words are really important. For many years, we've said, well, recovery is possible. It's possible to get better. We know when it comes to substance use conditions that recovery is probable. If an individual receives the support that they need, if we can meet that individual where they are, if we can seek first to understand what that individual has been through, and if we can seek to sort through what would be meaningful to that person, what an individualized recovery journey would look like for that person in front of you, rather than punishing people for, quote, moral failings, right? So it's moving away from punitive approaches, from incarcerating people with substance use conditions, from squeezing people, bottlenecking people into standard approaches of abstinence and AA meetings, or abstinence and inpatient rehab, right? Many of which work wonderfully for some people, but we need approaches that meet people where they are. There are 23.5 million people in the United States in long-term recovery from a substance use condition. And there are about that many people who are still struggling with harmful substance use or a substance use condition. And what I tell people who are beginning their recovery journey is that if as that individual heals, if they are to reach out a hand to one person who is still struggling with a substance use condition, what a difference we could make. And again, that's changing language, that's changing how we view substance use conditions, and seeking to understand so that we can reach out that hand and be available. We tell people all the time, recovery is probable. You can become one of those 23.5 million people who are in long-term recovery from a substance use condition. So key points today: substance use disorder is a chronic disease that primarily affects the brain. It's not a lack of willpower or moral failing. Recovery is the expectation and is probable, not possible, but probable, if people receive the support that they deserve in a non-stigmatizing environment. Let's reduce stigma together. Let's think about changing the language we use, seeing the person in front of you as a person first, whether it's a community member, a loved one, a colleague, someone that you're caring for in medicine or law enforcement or emergency medical services, whatever it might be. Let's change our language, let's change our thought process, and let's take a deep breath, step back, and try to understand where the person in front of us is coming from. To say, what's the person in front of me been through, rather than what's wrong with the person in front of me. So as a quick wrap up here, before we turn this over to questions, what I would love to hear is what is in a word or a phrase, something that you might consider doing to address our substance use disorder crisis, to potentially consider changing even one person's life, someone in your community, somebody that you know. Use more positive language, I'm seeing. Recovery is expected. I love it. Good. That's great. Empathize. Excellent. So that's really seeing the person in front of you as a person first, right? What have they been through? What are they going through? Beautiful. These are absolutely fantastic. Examine some of the punitive approaches for people that we're working with. That's excellent, right? Avoiding that punitive approach. I will say that anyone with who knows teenagers, who has a teenager that you love, that motivational interviewing works really, really well, right? If we have a punitive approach, we say, what's wrong with you? You're in trouble, right? You're grounded. That's sort of that old punitive approach that we take. But if we say, all right, there are consequences to your actions, right? But what I want to hear from you is, how'd you get here? What have you been through, right? Tell me about that. And that works really well. And I'll tell you, as we're in the midst of a stressful election, stressful for all, that if you're sitting in front of someone who you disagree with politically, some of the best ways to navigate those conversations are to take that step back and say, tell me about your experience. Tell me what you've been through. Tell me why you think the way you do, and just reflect that back. You don't have to change anyone's mind, right? But just think about using that motivational interviewing approach. I'm seeing other ideas using person first, sharing what worked with me, being transparent about family history. Good. So destigmatizing personal and family history with substance use disorder, that gets really important, right? We want to make sure that people with substance use conditions feel comfortable at home, in their workplace, right? At our hospital, I like to make a big push to say people in recovery are phenomenal parents, are phenomenal caregivers, are phenomenal people to work with. Let's hire people in long-term recovery, right? Destigmatize that history. not trying to be the expert. Excellent. We are not the expert of anyone else's lives, right? Let's see where they are, what they've been through. Tell me what brought you here today. Good, right? Tell me what you've been through. Thinking about ways that we can address policymakers, our lawmakers, right? Someone's commenting about some of the punitive approaches that are taken, especially with our youth. We know those don't work. They've never worked. So really thinking about ways to make that change. These are wonderful comments, and I'm so grateful for everybody's thoughts. What I'd love to do now is I'll turn this back over to Jennifer to see if there are any other questions or thoughts before we wrap up.
Absolutely. Thank you so much for this presentation. We do have a few questions in the chat box that have come, or that question box, excuse me, that have come through during your presentation. And one is a great question about folks who are incarcerated and how the community can help people who are sitting in jails. Maybe people who are working directly with that population or just someone that they know.
I think that is such a great question. As I mentioned before, I think our criminal justice system is working to evolve, and I think many times there are programs where some substance use treatment is being integrated into that incarceration period. I will say I think the successes have been mixed. And so I think one really important piece, whether we are working with individuals who have criminal justice involvement, or we have a loved one with criminal justice involvement, when we look at our communities, and particularly in our communities, persons of color are particularly affected by a very, very high rate of incarceration compared to almost every other nation in the world. So if you look around and look at our communities and talk to our community members, many people in our communities are experiencing someone they love or know being incarcerated. So I think really reducing stigma is a very key piece. Unfortunately, I think, and this is my personal opinion, that incarceration is the wrong approach. And so what we're struggling with is from my point of view, accepting that our loved ones are not receiving the care that they need necessarily. I think one important thing that we can do, and there are organizations working on this, are what we call a radical welcome. So when someone is released from being incarcerated, that we make sure that as communities, as families, as workplaces, that we radically welcome people who have served their time back into our communities and fight for the rights of individuals that have been incarcerated many times throughout history for nonviolent drug-related offenses, again, especially people of color, who then come back into our communities and experience ongoing stigma for the rest of their lives because of that history of incarceration. And if we as a community can fight that, if you work at an organization that hires people to say, look, can we please move past asking people questions about their history of incarceration? It doesn't matter. Once somebody has served their time and is released, particularly around nonviolent offenses, can we please welcome them back into our communities, our churches, our synagogues, our temples, our schools, our libraries, our workplaces, and try to reduce that stigma. Likewise, with people in recovery from a substance use condition, or people who are living with other stigmatized conditions, with psychiatric illness, for example, to say, we welcome you into our communities. That radical welcome, in many ways, when we feel powerless against the sort of systematic incarceration, that we can say, when you are released, we welcome you. We welcome you back as the whole person that you are, and let's give people a chance to recover from what they've been through, whether it's a substance use condition or mental illness, or having been incarcerated or stigmatized, or whatever it may be.
Excellent. These are so helpful. And, you know, sort of in that regard with the big picture ways to sort of shift the ideas, shift the paradigm around these stigmatization, these words, these approaches to working with folks. Can you talk a little bit about some of the policy or advocacy efforts that you've seen be successful in making those big shifts on the big level, on the big picture?
Absolutely. Yeah. So there are a number of organizations that are working hard to reduce stigma. You know, I will say that I don't think any of us have found the perfect way to address stigma. I think I consider myself an advocate for people with substance use conditions and other stigmatized conditions. And rather than saying I'm an advocate, I would say I strive to be an advocate, because it's a lifelong learning process. And those of us who joined on this webinar today, by joining this webinar, I think you acknowledge that you're a lifelong learner, right? That all of us are learning to be better community members, and that whether it's through your own actions or some of these larger organizations that are working to look at policy, to advocate for people with substance use conditions, to advocate for harm reduction approaches. All of those are pieces, and I think we all chip away by working in a place where we are comfortable, right? It's going to be a little different for everybody. In my mind, I think some of the most important types of organizations out there, and I won't list any specific ones just to avoid any bias, but I think organizations that are fighting for harm reduction are absolutely critical, because harm reduction by nature says, let's meet someone where they are. You don't say, don't drive, it's dangerous, right? I'm an emergency physician. I see people in our trauma bay, don't drive. I say, you know what? Live your life, drive your car, but maybe think about wearing a seatbelt, right? Maybe think about slowing down a little bit, right? Have a designated driver if you're using a substance, right? Harm reduction, I think, is really our best antidote at this point, to try again to meet people where they are, to say, maybe you're not ready to stop using today, but what we can do is meet you where you are and say, let's provide safe equipment. So there are organizations that are fighting against the federal ban on possessing a clean syringe. It's illegal to possess a clean syringe, even though people with, living with diabetes use syringes to inject insulin. You cannot carry a clean syringe with you. So people use dirty syringes, they share syringes, diseases are spread that way, and there are organizations that are fighting to provide legal access to clean supplies, to meet people where they are, to say, you know what, today your recovery looks like using clean equipment or keeping Narcan available. Maybe we'll work towards meeting you where you are. Maybe 3 weeks from now, we can work at using a little bit less. When you're ready for it, right? We're here to provide that support when that person in front of us is ready. We evoke that readiness from the person, and those harm reduction approaches align with that approach. Say, let's see where people are. Let's ask the question, what they've been through, what resources are available to them, and how we can best meet them in their recovery journey. So harm reduction, changing policies around access to expensive medications like naloxone, to illegal items like clean injection equipment, to providing that education. Those, I think, are some of the most important organizations. There are others that are working to decriminalize substance use, so that rather than incarcerating people for possessing an amount of a substance or using a substance, that we would provide access to treatment rather than, quote, locking people up. Again, those organizations are fighting for drug policy change to begin to move away from that very United States heavy process of kind of punitive approaches to substance use.
Excellent. Well, we are almost out of time, Dr. Beauchamp, and I just want to thank you so much for your time today and your expertise to this conversation. We certainly have a lot to learn as a society, And I think one of the big takeaways from this conversation is this idea of meeting people where they're at and seeking first to understand. And that as a great place to start as we all identify where we have to learn and grow and how we can support folks with substance use conditions. In respect of everyone's time, I'm going to go ahead and just offer you any last thoughts before we go. But again, a huge thank you to you and a virtual round of applause for that very informative presentation.
Thank you so much, and I'm really grateful to everyone who attended today, and thank you to the team who worked really hard to put this together. Fiorella and Lana and Yasmin and Jennifer, thank you for everyone for taking the time. I know everyone's really busy, and Jennifer, I think your comments about seeking first to understand and meeting people where they are, you summed it up beautifully. So thank you so much.
Wonderful. Thank you so much, everyone.